Yeah, so this is an ongoing project, very much not finished, where we are trying to estimate the indirect death toll in Gaza since the start of the conflict. And this was a request that came through from WHO, which Paula Kristen, who's working with us on this, is very much leading, as well as the team in WHO. So she's been on secondment with WHO for the last 6 months. But the kind of objectives that WHO had were to firstly kind of understand how much indirect mortality there is. So when I say indirect mortality, this is mortality that occurs not as a direct impact from the conflict, so not blast, specific trauma, in individuals caught up in conflict. It's the secondary excess deaths that occur as a result of the impact of the conflict on the health system as a whole. So the large malnutrition and famine that occurred, that would be captured in that. So it's not a direct conflict-related death. So the first thing is to actually estimate this, figure out what is driving that indirect mortality over time, where are the gaps in our ability to actually do this analysis, and hopefully as part of the rapid needs and damage assessment, if we have an idea of actually what's been driving indirect mortality, that can be used to inform where the specific needs are most urgent, and as part of the kind of costing exercise to understand the rebuild. But that's a different political issue to don't have time to go into. We know from previous conflicts that actually often indirect mortality significantly is larger than the actual direct death toll. So the war in the Democratic Republic of Congo at the end of the 20th century, less than about 10% of the deaths that they believe happened were due to the actual violence. Vast majority were due to disease and malnutrition during and after. And so that's where this question kind of came from WHO. But having done a mortality estimation exercise in Somalia and knowing the kind of data reporting systems and availability in Gaza, this request, my initial reaction was no, we probably can't estimate the indirect mortality, but certainly not in a way that is statistically robust. Or if we do estimate it, the uncertainty in it is going to be so large that we're probably only going to be able to tell you no excess deaths to 20% of the population, just because my guess coming in was that the data was not going to be strong enough. And so as part of this request, rather than kind of collect what data is available, have a go at statistically modeling it, wants to go back and kind of go from a purely simulation-based framework and see if we could understand actually, do we have enough data? Where are the possible biases? If there could be possible new data sources that could be collected. Again, a lot of this data does exist. It's about gaining access to it, actually going back into buildings and collecting it. How much extra value would that data add to this exercise? Because every piece of data collection incurs significant people and potential lifetime, especially if the conflict's ongoing. So we wanted to kind of come at this in a way that we could be confident about what we were saying, and also not waste people's effort in collecting more data if we truly didn't think it was going to have potential value. But as I say, as a context, so colleagues at the London School did work in early 2024 to understand the death toll due to conflict, again using a variety of different databases and what's known as capture-recapture. If you ever remember from school going out collecting snails, painting snails, putting them in the woods and collecting them again sometime later, and then using that to work out the total number of snails, kind of similar basis, going here are separate lists, capturing something, look at the overlap and use that overlap to understand the total. So that work looked at the direct death toll, but all that happened at that time was kind of scenario-based modeling of the likely future death toll under different kind of health domain models. So they had models looking at infectious disease, ones looking at maternal and neonatal, non-communicable, and malnutrition. And the reason we're mentioning that is because, again, at the time, they knew they didn't have any data to actually do a statistical model to actually directly look back at this, so it was all scenario-based. But the framework that is usually used for mortality estimation was sort of developed by Francesco Cecchi at London School, who I worked with, where they draw a big DAG of everything that they think can and will lead to mortality during a crisis. So it starts from beginning like exposure to armed attacks that directly leads to mortality, but also how that then leads to, say, forced displacement, how that leads to then interruption of treatment for chronic diseases, and so on and so on and so on, and how all these things potentially link and circle back and lead to eventually mortality over time. And so this is a framework that's been used by Francesco in previous humanitarian crises. Just kind of quickly run through it. So this is one we did in Somalia, but the framework kind of goes in a few steps. It's first, is there any actual ground truth mortality data? Do you actually know how many people are present at any point and over time? Population denominators, very hard to get. Do you have data on the predictors, so those areas of health? Can you use those to then fit a model to capture retrospective historical mortality rates, and then use that to then look at estimating the actual excess death toll during a period of crisis? So when I was at London School working on the drought in Somalia in 2022-23, they had just had 5 consecutive seasons of very poor rainfall, and the IPC, who does food security assessments at the time, was increasingly putting large numbers of the population into the higher levels of food insecurity, but were fairly close to declaring a famine within Somalia. And so we went through those kind of 5 steps. So we started by seeing what data was available. There are these surveys called Standardized Monitoring of Relief and Transitions, SMART surveys, but these are used for generally monitoring children and adult development. They do measures of malnutrition, but they've also included in that survey a small household mortality survey. So basically, how many people are in your household, how many people have been in the household for the last 60, 90 days, has anyone in your household died, left, etc., etc. And from those, you can then estimate a death rate, so how many people are dying per day over time. And what we had available at the time, so for each region in Somalia by time, how many surveys had been conducted. So Brazil, where the capital is, very heavily surveyed. Other parts, very few surveys. Some areas where there's instability and terrorism, basically no surveys have been done. So there's large parts of the country where we have no data. But that's not necessarily a problem if we believe our predictors and covariates we can collect are accurate and predictive. Secondly, population denominators. No one knows how many people are in Somalia, really. Specifically, really, how many people are in any one particular region. There are surveys done by the UN about how many people are displaced and move between each region. There is some data on how many people leave the country, but there hasn't been a survey for quite some time, and statistical models to kind of estimate the population size in each region literally vary from let's say like 500,000 up to sort of 2 million in one region, which makes it very hard when you're trying to take your mortality rate you estimate, multiply it by the population size. You can end up with very different death tolls. And then our possible predictors of mortality. So across all those health domains that we're looking at, that's kind of anything that's indicative of infectious disease, malnutrition, maternal and neonatal health, food insecurity. But we do want them to be hopefully available for each region where we have this data. And so what we had available from kind of regular reporting efforts that have been set up since the last famine in Somalia, we have indicators of malnutrition, incidents of armed conflict and combat incidents, which kind of in that diag leads to potential inability to access routine health service. Disease incidents for malaria, measles, and cholera were the most complete reporting. Food prices. So food prices are hoped to be indicative of the ability for an individual to actually purchase and provide calories for themselves and their family, but food prices vary very, very quickly. And then other kind of indicators of some kind of instability. These were the ones that kind of were most completely reported, but there are loads and loads of other indicators that we would have obviously wanted to have. And many of these indicators are not actually what we necessarily want. So one of the ones for malnutrition, what we would obviously love to have is representative surveys where we have gone out and measured levels of acute malnutrition, but often the indicator for malnutrition is how many people accessed food insecurity support through some of the UN agencies. So the number of people seeking support for nutrition, which is not necessarily, again, exactly what you want from that DAG. And also for all of those different indicators, we have different levels of missingness. So these are the ones that we eventually finalized on, in part because of their levels of completeness. There were other ones where we would have liked to include them, but they were completely missing for half the country, or weren't available for the last 3 years. And when we did a kind of data imputation, predicting missing data from that, it looked relatively plausible based on the covariates we had. It's a bit hand wavy. And going through this kind of experience when I did it, and noting that this is what's been done during kind of previous famine and war, it didn't make me feel very comfortable as a modeler or a statistician. There's a lot of gaps, there's a lot of uncertainty, and especially during the conflict in Gaza, where it's particularly politically sensitive about numbers of people who've died, I wanted something I could feel a bit happier reporting on, rather than this current approach. And while it's, I think was okay and helpful in Somalia and kind of could be used to inform kind of areas where additional support went, it had a different kind of context in Gaza. So why is this difficult to do? As you say, like all the usual data sources we would love to have, incomplete, disrupted by conflict, but also a lot of the data that we do have are proxies of things. So we have good belief that increased severe malnutrition is likely to lead to increased mortality. But if we only have available data on the volume of food shipments that have made it to a particular country, a particular region, does that necessarily give us some information actually on malnutrition? Does it have a weird inverse relationship with malnutrition? Are the areas where most food shipments are peaking at the areas where malnutrition is greatest, or actually is it just the area that food shipments can get to? So we don't necessarily know the kind of cause-effect relationship between the covariates we have and actually what is known to have a direct causal effect on mortality. So we first started by, and it's very much ongoing, going back to the DAG, simulating from the DAG that we have, and going about it from a pure simulation framework. So we start with that DAG that Francesco came up with. We can then simulate from it with known causal effect relationships. We can then be happy that it's kind of, we can put in it kind of what we believe from maybe previous conflicts or previous emergencies are the kind of known possible causal effect relationships. So it's not like we're simulating in a wildly unrealistic space. And if we have a simulation model, we can then use that to actually test what impact these kind of data missingness will have on our ability to estimate it. So we can set, again, believable parameters. We can simulate from that DAG. So we put in sort of known effect sizes. We simulate within particular districts over particular time periods. So we can simulate the full hypothetical synthetic population. And then we take away from the data. So from some of those previous experiences, we know we're going to have data missing completely at random, missing data systematically missing. We know that some of that data is going to be temporally sparse, spatially sparse, etc. So put in the patterns of missingness that we tend to see, but also the patterns of missingness that we are currently seeing in the data that's been collected in Gaza. And then from that, with that missing data, then we can go back, try and estimate the mortality with whatever statistical model you want, and see how that missingness has actually impacted your ability to say anything. We could then go back and say, well, actually, the current gaps that we've got available in the data are potentially insurmountable with new data. And it may actually just be that that data is with a particular stakeholder. We just haven't got permission for it or access to it. So it's go and follow up with more emails. Efforts to put in place a vital registration system and restart some of these systems now the ceasefire is happening, potentially could be looked into to try and add to those gaps in the data. But with the simulation framework, we can then hopefully actually say, we can do this analysis, we absolutely cannot do this analysis because of the level of bias and uncertainty we have in it. And if we were to do it, can we actually say anything actually about what is driving that indirect mortality? We might be able to come up with something that we'd feel comfortable coming up with, like a wide uncertainty on the total death toll, but maybe the actual ability to unpick which of those kind of health domain areas is really driving indirect mortality, we're less able to say anything with good confidence about. And that's, I think, one of the kind of key things they want is to actually understand what areas of health should be being invested in as we kind of start that rapid needs assessment. So Greg, who used to be here and is now doing his PhD at London School, is just about to start a WHO secondment. WHO really like it when people second for no money to them currently, just as an aside. So Greg is going to go do a placement with WHO to kind of help build this kind of statistical framework. Let's go for that. And then these are all of the individuals who have currently been consulted or engaged in this data collection exercise across very many areas of the health systems we've looked at. I've spoken to only a small handful of these people because Paula, who is working on this project, who's on secondment currently, has spoken and arranged meetings with every single one of these people. And she did it in the first 2 weeks that she was on secondment with WHO. She is an absolute machine, and is none of this project could be done without her. She is just phenomenal. So through all of these conversations, we're just starting to get some of this data to trickle through, some of the ethical agreements to come in place, and some of this data to come online, likely coming starts of 2026. So yeah, watch this space.